Hi, everyone. I just wanted to thank everyone for coming out, and on behalf of International Bipolar Foundation, I want to welcome you to our free monthly lecture series. I am Ashley Wrightson, the program manager for the foundation. Before I introduce our speaker, I just wanted to let you guys know about a few things going on with us and what we're doing, what's new, and events coming up. So next month, we'll be having our next lecture with Beth Cooper, Dr. Beth Cooper, and she's going to be speaking about spirituality, mental health with a focus on young adults. Our next event is on January 22nd, and we have been chosen as official charity for the Carlsbad Marathon. So you can run, walk, sponsor, volunteer with us. We're really excited about it. There's 24 other charities doing it with us. So that's very exciting. And then on February 24th, that's our annual Click event. It's instead of a boring gala, it's a game show. It's very interactive. Each table is a team, so you compete against one another. You learn a lot. We have thrown questions about bipolar disorder, sports. It's very mixed up, but it's very educational, and that's going to be at the Del Mar Fairgrounds this year. And then just kind of an update on programs. We actually just launched the first mental health awareness patch in San Diego for the Girl Scouts, which is really exciting for us. And I don't know if many of you are familiar with the Girl Scouts and how they obtain the patch, but you're a Girl Scout?
I used to know a lot of those.
Yeah. So we developed requirements for girls starting in 4th grade all the way up until 12th grade, and they have to, in order to earn the patch, they have to meet requirements, and it's not just bipolar disorder, it's any mental health issue going on, illness. So they go out in the community, they can interview someone, volunteer with a mental health organization. So it's really exciting, and we've gotten a lot of great feedback from parents and how their child has come out about bullying going on in school, their friend may be suicidal. So it's really opening up these girls and getting them engaged in the community and more involved helping with their friends. So really excited about that. And we also just launched a blog corner, and we now have 10 international bloggers, which is really exciting and unique because we get to hear the perspectives of how treatment, medication, resources are in different countries and all around the world. So if you guys have any interest, you can see me after and I can tell you a little bit more about it. Now I'd like to introduce a very special guest tonight, Dr. Irwin Rosenfarb. He is a professor in a clinical psychology PhD program at Alliance International University in San Diego, and he's the director of a family support center in San Diego. His teaching, research, and clinical interests focus on psychological treatments for individuals with serious mental illness. He was the principal investigator on an NIMH research grant and served on the San Diego County Mental Health Board. He has over 100 publications and presentations on schizophrenia, bipolar disorder, and depression. Tonight he'll be addressing family treatment for bipolar disorder, so please help me give him a warm welcome.
Thank you, Ashley, for that very nice introduction. It's really an honor to be here tonight and to have the opportunity to talk to you and to hear about all the wonderful work you're doing to reduce stigma and help people and provide support for people with bipolar disorder. It's really wonderful to see. It's really important work that you're doing. I want to talk to you tonight a little bit about family treatments for bipolar disorder. I don't mind being interrupted. Our video person might mind that, but if something's unclear and if you'd like me to go into more detail, explain something, given our time constraints. But if something's unclear, please feel free to stop me and then ask for clarification. And we'll also have some time afterwards for questions and answers if I can help and clarify anything that I'm talking about tonight. Okay, let's see. Family treatments for bipolar disorder. Let's talk a little bit about what is bipolar disorder. It might be this might be a little elementary for some people here, but then I'll talk about this a little more in detail during the talk. Persons with the disorder vary between extremes of mania, excessive energy, elation, or irritability, and depression, feeling sad, lacking energy, excessive guilt, or feelings of worthlessness and suicidal thoughts. When I started graduate school, there was the thinking was it was called manic depressive disorder, and the thinking was that if you had a manic phase, you were automatically going to have a depressed phase, that you had to have both. But now we know that's certainly not true, that a lot of people just have manic episodes, and especially males, and females are more likely to have depression in general. And so it's not necessary to have both the mania and the depression. We talk about differences between bipolar 1 and bipolar 2 disorder. Bipolar 1 disorder, someone who's had a manic or a mixed episode. A mixed episode is when someone has both manic symptoms and depressive symptoms over a 24-hour period, or they rapidly alternate between the two. And bipolar 2 disorder, which is a hypomanic episode. They don't have a full-blown manic episode, but they have a less severe type of manic episode. But people with bipolar 2 disorders also had to have had a depressive episode to get the diagnosis. We also know that a lot of people have more milder forms of bipolar disorder, and these criteria really don't cover the full range of people with bipolar disorder. And because not everybody who has hypomanic symptoms has had a full-blown depressive episode. So we know about 2% of the U.S. population has either bipolar 1 or bipolar 2 disorder. So and another 2.5% have more milder forms of bipolar disorder. You'll hear it referred to as bipolar disorder, NOS. But the more milder forms, maybe someone has some angry outbursts, some more irritable episodes, and they might alternate that with some more milder forms of depression. They don't have a full-blown depressive episode, but they alternate with periods of these highs of excessive energy, often striking out at other people, and some depressive episodes as well. We're talking about a significant problem that I want to make you aware of. We're talking about almost 5% of the U.S. population, almost 1 out of 20 people in this country have some form of bipolar disorder. So it is a significant issue in our society. The illness can be highly recurrent and disable. Another myth I had is, when I was in graduate school, we used to talk about manic depression or bipolar disorder. We was talking about, it's the rich person's disease of, Ted Turner, and now we have Catherine Zeta-Jones, and sort of it was almost socially advantageous, you could say, to have bipolar disorder. And it's sort of people, the thinking was you had an episode of bipolar disorder, and then you return to your high-level job after your episode of bipolar disorder, and we're doing wonderfully and just had these real isolated episodes. But now we know there are some people like that, and that's certainly true, but for more people, it's a full range. It can be very disabling and very disabling and debilitating for people to have bipolar disorder, and it can have a significant impact on family members. That it does lead to severe disruptions in people's lives. It can. Like I said, 5%, and people meet the range, go from the range of very severe problems to much more milder problems. And we often generalize, and everybody's situation is very different. But people talk about medications. Medications are critical in the treatment of bipolar disorder, in my opinion. They really do help people stabilize their moods. But only 40% of people take their medication consistently. That's a big problem. And the problem in general with illnesses in general, people don't take their medications consistently. But because of the stigma involved in bipolar disorder and the fact that it's often young people who see themselves as invincible and don't think that they have problems. I think people don't take their medications consistently, and we often, when I work with patients and families, I often stress that that's inevitable, that people are not going to want to take their medications. We should plan for that. And that's a normal part of having the disorder, is not thinking you have the disorder. That's part of it. And I think we need to sort of accept that and expect that for people. But the other thing to keep in mind is that medications are not the answer. And that's the other 2 points on the graph, why I put those down. And even if you take your medication, people often have relapse episodes. They often have the highs and the lows, even when they're taking the medications. And there's a lot of trial and error to the medications and difficulty finding the right medications for people. So medications solely aren't the answer, because even you could be taking your medications religiously and still be having episodes. We still know that most people will have an episode within 2 years, even if they're taking their medication rigorously. And we know that a lot of people have symptoms even when they're not in a full-blown manic episode or a full-blown depressive episode, that even in between episodes they may have difficulty concentrating, they may have milder forms of depression, they may lash out at other people, show some signs of irritability and anger, and show impulsiveness, even in between episodes. So it's not, we can think of the disorder, again, as usually that people have an episode and go back to normal functioning. That happens for some people, but for a lot of people, they have symptoms all the time, even when they're taking some medication. So that's a normal part of the disorder and something to be expected for some people, not everyone. Why get family involved? Well, first of all, we know that medications alone aren't the answer. I think that's the first reason, is that we need more. We need to do more for optimal treatment of people with bipolar disorder. And there's a lot of research showing that family stress can really play a role and really cause a lot of difficulties, not only for the person with bipolar disorder, but also for their family members. Family stress is known as high expressed emotion, can play major roles. When families live in high stress, when there's a lot of stress going on for the person with bipolar disorder, when they feel a lot of stress, when their family members feel a lot of stress, patients are 2 to 3 times more likely to relapse over the following 2-year period than when families don't have a lot of stress. And I think that's a really important point, that stress really can impact. And again, it's not only just bipolar disorder. We know that, not only for mental disorders, but medical disorders as well. That stress really exacerbates a lot of problems in our lives. So, and you all know that already without me telling you that. But so the way we can minimize stress or reduce it as much as possible, the better off we'll all be in helping people, helping all of us. The first study, and really the major study that showed the importance of stress, was done by one of my mentors, David Nicholas, who will be coming here to give a talk. He's at UCLA for our study before I came down here, and he'll be coming here in December. I'll be talking about several of his studies. And yes, sir.
I just want to know if you're going to make your presentation available to us.
Yes, I don't know. Is that going to be available on the website or
Yes.
the video?
Thank you.
Yes. When families showed a lot of stress, if they had stressful communication styles, they have trouble communicating with each other. What Nicholas found in his study was that 94% of patients had another relapse episode within 1 year. But even more importantly, when families didn't have a lot of stress, only 16% of patients had a relapse episode in 1 year. Interestingly, in his study, what he found is that, that's the next point is not surprising, that most patients didn't take their medications consistently. But in this study, medications didn't predict how well patients did over the 1 year follow-up what seemed to be most critical is, and what he, let me go back, that family stress may be a more important predictor of how well individuals with bipolar disorder do after they've had an episode than whether or not they take the medication. I think that's a pretty profound finding, is that what he found in his study, and there's some other research on that as well, is that medications are important and they're critical, and I don't want to minimize those. But family stress, I think, sort of can I don't want to say the word override the effects of medication, but they sort of definitely can exacerbate the problems, make the need for medications less likely if stress is reduced. They make the need for medications less likely, and if there's a lot of stress, I think people would require more medications. So I think it's sort of, they interact with each other, and I think if stress is kept low, medications become less necessary for people with bipolar disorder. The need for medications don't go away, but I think they become less critical. And if we can minimize stress in people's lives, well, how can we do it? It's easy to say it, but can we really minimize stress in people's lives? I want to say these things. No evidence that family stress causes people to develop bipolar disorder, that there isn't any evidence. There seems to be a strong biological, genetic component, and there's a lot of research on that right now. We don't have a really good understanding of what that means, and what are the genes that involved and how it gets transmitted genetically. But there's no evidence that stress plays a role in developing the disorder, but once they have it, people have the disorder, that stress can exacerbate symptoms and make them worse. And most families, though, don't show high stress communication patterns. Most families are really tend to be supportive of each other and don't have stressful or negative interaction patterns, except when symptoms start emerging. And I think that's when you see these, it's really an interactive situation that patients start acting worse, family members start getting stressed, they get nervous, they worry a lot about what's going to happen to this person. If they're not taking their medications, they see things get worse. They act in ways that sort of, maybe later on they might regret, or may make things worse. They don't know how to talk to that person, their family member, who has the severe mental illness, to get them to see that I really care about you, I really love you, and all you're hearing right now is my anger and my negativity and my wanting you to sort of shake you and say, please, please can't you see what I'm seeing? And that's really hard. That's a really difficult thing to do. But the good news is I think most families can be taught to reduce those stress levels in their life. And I'll show you some research about that. And that when families change their family interactions, when they start communicating in low-stress ways, when they are able to minimize stress in their lives, that individuals with bipolar disorder show improved outcome. As stress goes down, people do better. As stress goes up, people do worse. It sort of makes sense. Okay, I'm going to try to keep track of time here. Well, what can be done to help families who are feeling stressed, to help people communicate more effectively? The most effective treatment for bipolar disorder, the most effective family treatment, is known as family-focused treatment for bipolar disorder. And Mikowitz did a study in 2003 in which he worked with 101 bipolar patients who had a mean age of 36. They had an average 6.4 prior episodes prior to being in the study. So it was a real significant, severe problem. Families either got 21 sessions of family treatment or 2 sessions of family treatment and then therapy as needed. So basically, it was a what we call a randomized controlled trial. And so 21 sessions over a 9-month period. And results indicated that 52% of the people who had the family treatment didn't relapse over 2 years. Remember, these are people who had an average of 6.2 two relapse episodes over the course of their life, so not relapsing over a 2-year period. And this is despite the fact that they were all taking medications, but only 17% of those who received just treatment when they were showing during crises time, during a time of crisis, failed to relapse over the 2-year period. So this was despite the fact that they were taking their medications on a regular basis, and they got very good treatment, medical treatment. But the family treatment really made a significant difference. Let me talk about 2 more studies. Ray et al. In 2003, this is a study that I was involved with up at UCLA, and I was fortunately was one of the therapists involved in the study. Ray randomly assigned 53 bipolar patients to either 21 sessions of family treatment or 21 sessions of individual therapy, individual case management. So the therapy was the same. It was either individual or family therapy. All patients received medication. Interestingly, this study didn't show that family treatment had a significant effect while patients were actively involved in treatment, but once they stopped treatment, only 12% of those patients who received the family treatment had a relapse episode. And again, but over the same period, 60% of those who received individual case management had a relapse episode. So again, this study was important because it showed that both groups got an optimal medication management. They were both treated by the same psychiatrists and really got very good medication. And both groups got therapy, and the therapy was the amount of time in therapy was controlled for. It's whether you got the family involved or not. That's what really made the difference in this study. It's getting families involved. And that's really what, I sort of keep stressing to people all the time as I tell people I work with, I can only see you an hour a week. Your families are with you all the rest of the time. Who do you think has more of an impact in your lives? Who do you think can have more of an impact? Who has the potential to have more of an impact in your lives? Families, they've been with you your whole life. You've built up this relationship, changing families. Families, sometimes, unfortunately, they don't care, but a lot of times they do care. They may have difficulty showing it, and people may burn their bridges because of what people with severe mental illness have done to their families. But getting families involved and sort of utilizing your family can really be a powerful change agent in my experience. Getting people sometimes to see that and to believe that, it can be difficult. So.
Excuse me.
Yes, ma'am.
What was the average age in that study?
I don't know. They were predominantly adults with bipolar disorder. It was all adults, so I would assume it was probably in the 20s to 30s. We worked with some. We used the term family loosely in this study, and it included even children were family members. Children came in treatment. A lot of siblings came as well as parents.
Children of a parent, adult?
Right, who had bipolar,
I see.
Disorder. And they could be even friends at times, close friends. But they were all adults who were having symptoms of bipolar disorder. One more study Bickwitz did is the really only treatment study that's been shown to be helpful for adolescents with bipolar disorder. He again compared 21 sessions, so it's not a lot of therapy really, over a 9-month period, compared to 3 sessions of family psychoeducation, where families are just provided with information about bipolar disorder. Adolescents' mean age of 14.5. They had to have either a manic or depressive episode within the past 3 months. The adolescents receiving FFT recovered from depression quicker, and they spent fewer weeks depressed over the 2-year period. Interestingly, this treatment with adolescents, it didn't find any effect for mania. the family treatment just for depression. And that was a surprising finding. And they're still trying to work out what went on or why it didn't show any significant effects for mania. Was it something different about the adolescent? Was it something different about adolescents? Or is it just the way the treatment was implemented in this particular study? So there's been a lot of research trying to figure out what's going on there. But so far we don't know exactly, and we're still working on how to adapt these treatments to work with younger age groups. And that's really an important area of research right now. How can treatment, because the earlier we start, the better off I think we are in terms of helping families, helping people with the disorder. All right, what goes on in these family treatments? A couple points. No one form of family treatment has been shown to be better than any other form of family treatments. And the review article said there was a remarkable consistency in the various forms of family treatment. I say that to say people think about, ask me what kind of a therapist should I see or who should I see, and is it critical that the therapist use the exact treatment module that's outlined here, and I don't think so. When I tell people, my personal belief, it's more critical that you have a good relationship with your therapist, you trust your therapist, that's someone who understands your problems, who understands your point of view, who sees things from your point of view. That's the research suggests that's much more powerful, much more important than specifically what the therapist is doing, in therapy. Do you feel like that you're being heard and being understood? What doesn't work? Short-term treatments don't seem to lead to lasting change. These family difficulties have been going on throughout, the course of your life. You can't solve these in 2 to 3 sessions. Treatments that last less than 6 months don't seem to have lasting impact. Treatments that don't include the person with the disorder. I think family members often come in for treatment and they feel better, but I think you need to get everybody in the room. I encourage it, trying to get everybody in the room, even though that's incredibly stressful and difficult and people don't want to do that very frequently, but that's the way to make changes, because talking about changes is very different than actually seeing the changes and working with an entire family to make those changes in the room. And so I really encourage you've got to see the person who has the problems to really make the changes that are going to be lasting. Just learning about bipolar disorder is great, but again, unless you really, in my experience, unless you're hands-on and working with making changes and changing what's going on in the family, we don't see those lasting changes. I think, again, education alone, you learn a lot, and that's very helpful, and it's really helpful for family members in making, sort of feeling like they're being supportive and they're understanding what's going on. So education and reading is really critical. You got to watch what you find on the web. A lot of times it's often hit or miss, but stick to the International Bipolar Foundation website. And they have a lot of really good information about bipolar disorder. But to reduce stress, I think you really need to work with the whole family and just reading about problems is not the same as actually getting in there and working on the problems. Yes, ma'am.
Something when you say like work as a provider, I think it's important because when we bring the family, I think something that happens is the families are stressed out and they don't know how to respond to the patient. So I think part of the job of the therapist is also to coach, to psychoeducate the family members how to respond, how to talk, and how to find their own outlets to deal with the patient.
Right.
So
Right.
I think this is important too, because sometimes what I feel is that sometimes they're at their end, they don't know what to do, they're frustrated.
Right.
So they become another patient for another session.
They become what? I'm sorry?
You become a second patient.
Oh, second patient.
A second patient, because they need to vent.
Yeah.
They need to talk about their own distress and frustration. So
Yes.
I think to validate that and to let the family members
yeah.
know that it's a normal feeling, that it will sometimes occur.
Yes.
But also there are ways of coaching and responding
Yeah.
to good
Yeah.
patients when they are having their manic episodes or they're depressed. So I think it's important.
Yeah, I mean, I often ask family members, what have you done for fun this week? You know, and they look at me like, well, what do you mean? I'm dealing with my child in crisis. You know, well, it's fun, but have you taken care of yourself this week? Well, you know, that's real critical in terms of, you know, thinking about your own mental health. I think, as you say, you know, really taking care of yourself is because it's hard to do. It's really hard to do, and our society doesn't encourage that a lot, but it's really important. It's not good just to sit there and vent feelings. There's a lot of research shows that you're just sitting there and you know, and bringing up the past is not important either unless it relates to something going on. You know, I think, you know, rehashing what went on at age 3 and age 4 and then going on, you know, year by year, let's talk about that. It doesn't help anybody. Let's talk about what's going on right now, how we can solve problems right now and work on problems right now, unless the past sort of relates to what's going on right now and sort of impacts what's going on right now, then it can be important. But just to rehash things from the past, I think people end up feeling more wounded afterwards. So I personally advocate more of an active problem-solving focus. Let's work on what's going on right now and how we can change and be helpful to everybody in the moment. Okay, the common goals of family treatments. Understand and accept psychotic experiences, such as delusions and hallucinations. Help people to accept those experiences if they have them. What does that mean? How do we understand that? How do we integrate that into their personalities? I think it's very important to accept one's vulnerability to future episodes. The fact that, you know, again, adolescents feel they're invincible. I really like to make the point, you've had an episode, the odds are you're going to have another one. Let's plan for that. Let's talk about that. Let's see how we can help minimize that, help make it less stressful for everybody. Accept the need for medication to help control symptoms. Understand the significance of stressful life events and how stress can trigger different episodes. Help people distinguish personality traits from the symptoms of bipolar disorder. That's a very hard one to do. You know, I personally say I'm not manic. I'm just an irritable person. That's who I am. Accept me the way that I am. Yes, ma'am.
Can I ask another question?
Sure.
Since you're talking, I think that's something that I struggle a lot when it comes to make a diagnosis. Is because my question is about anxiety. So when is anxiety and when is a bipolar episode or manic episode? So because I was talking to psychiatrists, so it could be anxiety, excessive anxiety, being anxious about everything, the beginning of the development of bipolar. So when we can you help me out
yeah.
with that?
I have, let me go over I have a slide on the symptoms of mania. It's a lot more than anxiety. I think there's sort of, you know, it can be very destructive, I think, in people's lives in a way that anxiety isn't. So I'll talk a little bit about the symptoms. Okay, I'm just a moody person, you know, I'm just feeling sad. Well, that's who I am, you know, it's, again, and that's very difficult. It's very difficult to sort of, it's a fine line, and it can be difficult to make those judgments as to what is a symptom and what is just your personality. Okay, I'm going to go quickly through these because I see your time is going. Engage the family early on in a no-fault atmosphere, avoid blames. Families, I think, if they're coming into treatment, they're way ahead of the curve. To me, the vast majority of families don't come in for treatment. They don't get help. I mean, families are coming in and hearing talks, going and hearing professional talks. They're way ahead of the majority of families. There's a lot of other things you could be doing on a beautiful evening in October. You're not here, you're not here, that in itself is effort that you care and it involves. So this effort of let's try and the families are complaining just just baffles me, because obviously people wouldn't be so involved if they felt like this, if they're, were these mean and terrible parents. They wouldn't be spending their savings and doing all these things. So there's some, it's, we need to keep some perspective here. Families coming to treatment. We need to talk about education, communication, training aimed at improving communication clarity, and problem-solving training. I'll go over that in a little more detail. I'm going to go a little quickly on these slides. And then we talk about crisis intervention. What should we do when there's a crisis, when we see signs and symptoms of people having signs of their disorder? All right, let's talk about education. What goes on in education? As the lady said, it is very important that we do educate them. This is a handout I give to people. What are the symptoms of mania? The first symptom often is a decreased need for sleep. Not sleeping regularly is the most critical symptom in leading to an episode of mania. And one thing to tell someone who has bipolar disorder is that get a regular sleep cycle. That's really critical for people. And there's some research just taking an airplane trip and going to different time zones can disrupt your sleep cycle and can cause manic symptoms to increase. So it's really, people are very sensitive to sleep, and I really think getting a good night's sleep is really important. We have grandiose beliefs, increased distractibility, and also the impulsive, the dangerous, or the irrational behaviors. Judgment becomes impaired during a manic episode. Increased sexuality, especially you see that more in women than in men. With a bipolar disorder, men are more likely to do things like gambling and sort of things that are sort of very driving impulsively. So their judgment gets impaired in other ways than do women, although there is a lot of overlap. From there, speech becomes very active. It's that impulsiveness, very quick. Person feels like their thoughts are racing, and so it's different than anxiety.
But you would think mania. What about hypomania, like cyclothymia, and it's not so drastic? And this is something that I always question: is like when we know that it's not anxiety, it's the beginning of bipolar. It's when a person started to develop the symptoms. When there's a family history, but the person is just exhibiting, it's just being anxious because there's a lot of stress. And maybe somebody else would handle that stress without reacting so anxious.
Yeah.
I wish I
But,
could
yeah,
explain more, but
Maybe we could talk afterwards, because I don't see that as anxiety so much.
You're not able to sleep for a whole week. They told the medication in the world to sleep, but you can't, like, you got 5 days in a row without sleeping. And there's no way.
No, that's very common. One of the first symptoms is, as I said, is the sleep. Yes, sir.
Does trazodone work good with Paladol?
I'm not a medical doctor, so I really.
Well, I'm saying I take trazodone and I sleep like 10 hours a night. And how's the same for her?
Oh, it's not for me.
Oh, I see. Does it work for you?
Yeah.
Oh, good. Yeah. It's very individualized, the approach, and if you find something that won't work, stick with it.
Yeah.
That's what I tell people. Don't change.
All right.
Good. Yes, ma'am.
I'm very new to this. My young son was just diagnosed, so I understand, things present differently in kids, and there's the whole question, of course, is it truly bipolar disorder? But how can you distinguish some of these that are found more in younger children?
You're going to find more of the impulsivity in younger children. Those are That is one. Increased distractibility, some in the depression, some in the pressured speech, and also the irritable mood. You don't find as much sort of the high, but it's more the irritability. It's the anger. So they don't go through, children don't seem to have these episodes, but it's more these short bursts of energy. Sure.
So what I understand, I mean, the terminology, I guess, cycling.
Right.
I mean, and so, I mean, I could see it 20 times a day. I mean, I don't know if this is truly this kind of cycling of an episode and you know,
yeah.
exactly how that.
I don't know either, to be honest with you. I don't know. It's different. It is different than adults with bipolar disorder. But I do know for a lot of kids, the medication seems to help. So in some ways, I think, well, you know, does it matter what you call it if the medications are helpful? I mean, we do have to worry about the medications a lot, but I think there is some benefit to it. But it's different. Yes, ma'am.
I have a young child with bipolar disorder, and I see the impulse. I see rapid cycling, like up and down, up and down. I mean, and one instance would be like we were all on the couch and we were talking and we were laughing, having fun, and something that I said was funny, and my child was laughing and laughing, and then he turned and got enraged and got angry because we were making him not be able to breathe because he was laughing so hard, and he ran upstairs and just started to cry, and then came back downstairs because I didn't react to it. I stayed on the couch and just let him do his thing, and then he came back downstairs and the same exact cycle happened again. You know, and so I don't know if that's what you're seeing, but I also see the sexuality. My child is 9 and since 7 has had hypersexuality. They just wanting to dress provocatively, wanting to get people's attention, very much obsessed with that.
That could be something else.
It could be, yes. But I think in combination with the other symptoms, it might be due to bipolar disorder. Yes, ma'am.
I had a question. I'm told that in teenagers, it first gets manifested because somehow it's triggered by hormones. Is that?
We don't really know the answer to that. I think that's still unclear. I mean, and a lot of kids we start showing symptoms younger than before adolescence. So I don't know that there's anything critical about adolescence.
Okay. And my second question for that is, have you heard about an adult presentation in a child? Like, is there something characteristically different between the presentation of a child up to, I guess, 18 versus 18 and up?
Well, they're much more likely to show more hypomanic symptoms than true mania. They're not much less likely to show the more psychotic symptoms, although sometimes you do see that in children, like hallucinations or a full-blown delusion that someone, let's say, in a manic episode would have, where they're out of touch with reality. You're not going to find that sort of significant impairment in somebody, typical, in a child. So it's
Would not be typical.
okay. Yeah. Mm-hmm. Yes, sir.
You said that 60% of the people who do take their medication still have a relapse within 2 years. Well, what about people who don't take their medication, stop taking it?
Yeah, that's a good question. We don't know a lot about those people because they're often not coming in for treatment and they're not being followed, so it's really hard to have good data on that to really know how people are doing. But my guess is, the estimates are it's upwards of 75 to 80% of people who are not taking their medication.
And does it have to be that they have a second and third episode when they finally realize, well, you know what? This is how it is when they...
Yeah.
It takes, in my experience, it's about 3 to 4 years for the person to actually kind of own and admit. They go and they feel better, they take the medication for some time, they stabilize, they feel great, they feel that they don't need it anymore, or they miss the highs. It's typical, they feel they miss the manic serious mistakes, and then realize I have to go back in on medication. But they didn't understand, they didn't want to admit, they feel denial, they hate themselves, you know. So it goes for like 3 boys until they fully understand and admit and own and say, okay, I do have to take medication, I do have to do therapy, I do have to take care of myself. This is insane.
But you know, I tell people it's sort of healthy to fight the disease or healthy to fight the disorder. I mean, when you're 18 or 19, who wants to think that you're going to take medication the rest of your life, or that you have this major severe mental illness? No one wants to think that, and the denial, in a way, is adaptive and healthy and signals some struggle to want to be normal, which is good, which is, I think can be really positive. So you got to find a balance between that. It's, you know, you do. Mm-hmm.
Without your undermining the importance of medicines, it sounds like you're not a firm believer that that's the only direction or avenue you have to take.
You know, what I tell people is that, first of all, I tell people go at least a year without having an episode before you get off your medication. And then if you're very good at noticing an increase in your symptoms and can go in and get help when you notice the increase in your symptoms, then I think it's worth a trial. But a lot of times the symptoms come out of the blue and they just appear in a full-blown way. Some people, it's much more gradual than other people. And those people, I think, can do much better off medication because then they can get back on when they notice the symptom. And it depends. Are you going to be sensitive to what other people notice changes in you? Hey, you're not the same as you used to be. You know, you seem a little more irritable, a little more jumpy, you're harder to follow, more distractible than you used to be. So it's very individualized, I think. So, you know, I think there are people who are aware of their own symptoms who can be okay without medication, but, you know, it's easy to deceive yourself, too. Someone else was going to say something? Yes, sir.
I also feel like part of the denial is not just the person with the bipolar, but the family, and that's
Well,
where
yeah,
the family treatment, I think, comes
Yeah.
into play.
Right.
Because when you
Mhm.
have a child or a young
Mhm.
adult, an 18-year-old, and they develop this, you know, disease, and they have to be on medication. I mean, I know for myself, it was difficult to accept that. And I probably was encouraging, okay, you can get off the meds, you know.
Right.
I didn't help in that regard.
Yeah.
I think this is where I think family care is really
Yeah,
important.
and there's still a lot we don't know. You know, we don't have the answers about when you take meds and which meds, and you know how to balance all that. How do you balance family treatments, individual treatments, medication? It's very complex. Very complex disorder.
I was just going to say, that what about denial? A lot of the people who do have the disorder minimize it, or I know in my own personal experience, it is genetic because my family, multiple layers, have the disorder, and each of us have our own symptoms, but it's the recognition of, hey, I'm not doing things the way I normally do, or seeing that something has thrown me off that has made me start to cycle, and then the realizing it and being able to do the cognitive therapy and disassemble what caused me to become upset is sometimes very difficult because I can't explain to the other people that are around me what it is that caused me to cycle.
Mm-hmm.
And the easier way is to push them away, because that,
Okay.
you know, to force them to not
Yeah.
be in contact with me, because that helps me to isolate. And what you have to recognize is the people that have this disorder want to be left alone a lot of times. And I have 2 family members that were both my age or slightly younger that have passed due to this disease. And I just know that if you have a family member that has the disorder, stay in contact no matter how difficult they are.
It sounds like you have a lot of insight.
Oh, gosh. Oh, yeah.
I
I remember. I had heard or read something about the possibility.
know we're sort of moving on in time, so go ahead, I'm sorry.
That sometimes, or is there a question out there that is being looked at about this remitting? You know,
I'm not sure what you mean.
that the actual disorder may not be a lifelong disorder.
I think that's definitely possible for some people, that they sort of can have some episodes as they get older. They might have more milder episodes. They may go longer periods of time with episodes. I think, you know, I don't think it's inevitable that it's going to take a chronic downward course. You know, I don't see that. I think there are a lot of people who can cope very well. And you know, I see people who they'll go through their 20s and have a really hard time, and then come out of that and find some sort of peace with themselves after that, and sort of find some way that they make it work for themselves, so that they can monitor themselves, they notice their symptoms. You know, what do they need to monitor to get back on medication, and they're able to find some sense of peace after multiple episodes. So there's, you know, we find all sorts of different patterns now, I think. Let me quickly go through these. The symptoms of depression, most of us are pretty much more familiar with these than the symptoms of psychosis. I go over, we talk about negative symptoms, and those are more relevant for people with schizoaffective disorder, or rather than bipolar disorder. But these will be up on the website if people want to take a look at them, so I'll go through a little. I really think it's important when we talk about education and symptoms that each family member talks about their own symptoms, because kids often don't know. Parents try and hide these things from their kids, often as a way of protecting their kids. Well, I don't want to burden you with my problems. I don't want to tell you, but frequently, you know, parents have their own difficulties with anger, their own difficulties with irritability, difficulties with concentration, with trouble sleeping. Certainly, depression is very common. I think the more we can share about each other, make that less hidden within the family, it really, not only does it relieve our own burden, but I think kids can really learn to empathize and see they're not alone in having these symptoms. I'm going to go quickly about these people. How do people get these symptoms? They're born with genetic or predisposition. The environment becomes more stressful, although again, there's no evidence that the stress by itself will cause the disorder. We now know that in some cases, substance use can set off an existing biological vulnerability. Now, really, someone who has the biological vulnerability and is using drugs, using marijuana, that they can often exacerbate a lot of the problems, make them a lot worse. How can the family help? We've sort of talked about these. Reduce expectations. That's a really, really important one, and hard to do, and hard to find a balance with kids without psychiatric problems. How do you find a balance between your own expectations and, you know, what's too much and what's not enough? How do you push them without pushing them too hard? And it's even much more difficult when a child has psychiatric problems. Encourage participation in low stress, accepting activities. These are handouts I give about recent life events, things, how do we think about stress, what is stressful. I'll expect you all to memorize all of these by the end of class. But the thing that's interesting about this, I like to point out that positive things can be stressful as well. And actually there's some evidence in mania that positive stresses can exacerbate manic symptoms, things like getting a new job, and romantic relationships, starting a new relationship. You know, there can be on a vacation, starting dating someone new, fell in love. Now, positive things can be stressful. And again, I think also I like everybody in the family to talk about what stress have they experienced. Let's share it also that again, let's take the myth that parents are invincible too out of there, and that we're all in many ways struggling with some of the same issues. Okay, in case first page wasn't enough, there's even more stressors in our life that you can never get away from here. All right, I like to do the relapse drill. What should we expect? What do you want to happen when I, as your family member, notice the recurrence of symptoms? What do you want me to do? How do you want me to handle that? Let's do like the fire drill. Let's do a relapse drill. Let's plan for it, and let's talk about what's gonna happen there. All right, 4 basic communication skills. First one is positives. I like to start with this because none of us has enough positives in our life. We can always improve positive communication. Let's talk about what did you do good today? What did you do that I liked? Who pleased you? What did that person do that pleased you? And how did you let them know that they pleased you? Even more important, that's really hard for us. There's some research like in teachers that find that they're 5 times as likely to criticize kids in class than give kids in class positive feedback. And because we as a society we're easy to find the flaws. We don't really think about, hey, what did you do that I really liked? And how did you really handle that positively? And then we work on communication skills, listening skills. What would I like you to do different? Very behaviorally, talk about exactly what person could do differently. What would you like them to do differently? How can they handle the situation differently? Again, don't bring in the past and don't bring in everything else that they're doing. Let's talk about one example, one concrete situation. How can we handle this situation differently? And don't tell me about the 10 others and everything else that's been going on. And then negative feelings. What don't you like? How do you feel? When you do this, when you don't clean up in the kitchen, I really get angry at you. And what can you do in the future so that I don't feel this way? How can we communicate more effectively? Basic problem solving that you would do with any child in your family. Basic communication skills. They're no different, except it's incredibly different. It's no different, but incredibly different because so you often have to repeat it again and again and again and say it in clear and concrete ways. Solving problems, that's the last thing we work on. Let's figure out solutions to problems. We'll talk about the most common conflicts. The patient over-identifies with their illness. Hey, I have bipolar disorder. Don't have any expectations of me, right? No, you're just being lazy and afraid. Don't expect me to help out around the house because I have bipolar disorder. I can't do anything. I have this disease or disorder or whatever it is. So the patient over-identifies, and the parent is taking the opposite extreme. You're lazy. And so denying of your symptoms. And then you, as I said earlier, I'm not irritable, I'm just an assertive person. This is who I am. You're too sensitive, something like that. That's not my symptoms at all. I don't know what you mean by hypersexuality. This is who I am. Accept me for who I am. Versus, well, you're getting sick. You're really having symptoms, and you need to get a handle on this. This is not who you are. This is not what I see. This is not the child you were. Most common problem areas that we find in families, medication use, as we've talked about, especially with young adults, adolescents who don't want to take their medications. It frightens family members, which is understandable. You don't want to be on top of them. You don't want to count their pills or anything. But at the same time, you don't want to see the consequences of another episode. there's no good answer to that. It's really a struggle. When do you go back to work? When do you go back to trying working full time, back to sort of getting out there and dating, and how do you resume your prior life? Life trashing refers to the person who says, I'm going to be totally different now. You know, you see that after someone's stopped using drugs or after they've been drinking. Everything's going to be different. No, I'm not going to hang out with those people anymore. You know, I'm going to turn my life around. Well, we don't just turn our life around. You know, who are you going to be friends with? You're not going to sit at home, you know, all day. How are you going to change your life? Let's be realistic here. You know, what are we getting out of that? That partying all the time, that going out all night. Let's talk about what was fun about that, and how can you replace that in a way that's meaningful, in a way that doesn't put you at risk, where maybe you can get enjoyment. I don't expect you to be a hermit and spend all your life, inside and lock the doors, but how can you do it in a way that we all feel safe and comfortable? And relationship, living situations, you often find adult children moving back home after they've experienced some episodes of bipolar disorder, so they're regressing and becoming, children. Again, they don't want to live in their parents' house, but, the parents, and it's difficult for parents, but yet they're not ready. When are you ready to live on your own? Should you go back and live with those roommates? Can you live alone? Those are all struggles that we find in families a lot. And thank you. Thank you for coming. I'm happy to stick around, answer additional questions. Feel free to call or email me if you have additional questions later on. I can use some help if something comes up. Yes, ma'am.
How do you find therapists that actually, do family therapy? Because it took me a while to really find that. I mean, most of the therapists want to have the one-on-one, like my son was 18, 19, and I sort of want to have me or anybody else in the room. So it's not easy.
Well, that's the answer right there. Yeah, it's not easy. You're right, and often even people who are family therapists, they haven't been trained in severe mental illness. So they don't know what's going on. They're not used to working with psychiatrists and finding that balance. So, no, it's not easy, but it's like the medications. It's a lot of trial and error. And like I said, it's a lot of going to see people until you feel somebody who, hey, this person understands what you're going through.
Yeah, I find it demanded. I read Richard Rich's books and I
Did you?
demanded out of a psychiatrist.
Good.
Yeah.
Good for you. I mean, it's, a healthcare system is broken in a lot of ways. It requires a lot of people to take the initiative on their own and to sort of take the bull by the horn. It's not a good system. The onus is on you. But at the same time, you should be spending more time finding a therapist than you did deciding which car to buy last time. You should put more effort into that too. So you have to take some responsibility. Yes, sir.
NAMI also offers some very good support groups for families.
Yeah, thank you. Thank you for mentioning that. NAMI is a great resource for people.
Say that again?
NAMI, National Alliance for Mental Illness.
Family to family, peers to peers,
Right. I think their website is NAMISD.org. And they have monthly meetings as well. They're not just bipolar disorder, they deal with all sorts of, but they're geared to helping families. That is their primary mission. Yes, ma'am.
I understand the value of, family therapy. But at what point, isn't there a point when the family gets burnt out? I mean, at what point, how much can the family take, and how much abuse can the family take before the parents just get burnt out? And as much as that's proven to be successful, how much abuse do you take?
I don't have the answer to that. I mean, that's the question. But you're here, so that tells me that you want to be there. You want to be there. You care. And often just saying that you're available and that I'm here for you do you not, you gotta wait for the person to be ready to take advantage of what you have to offer. And they may never be ready. That's the unfortunate truth. That's what.
What would be the process to become a participant in a study? If you have a family or a group that you feel would benefit and or would be beneficial to the community of mental illness, to be able to be, one, respected as research participants, and two, to be allowed the benefit of the support which you might not otherwise be able to afford or utilize.
Yeah, no, that's a great question. I don't have any research ongoing right now with families that I'm working on, but maybe in the future I can.
If you want to see me after, we have some researchers who are looking for participants for different studies. So I can pass that on to you.
Yeah, I have 2 teenage adults that might be interested in participating.
Great, great. Yes, thank you. Thank you so much for coming.
Thank you.
Hi, how are you? Thank you. Thank you so much. Oh, sure. Did you see the little restaurant?
Yes, I do.
Oh, good. Hey, where's she? Oh, sure. Thank you for coming. Thank you. Yeah.
One second.
Well, if you need my card, I'd be happy to meet with you. We can, why don't you give me a call or email me to set up a time? And, Sure.